everyone, and welcome to Rad Chat, the first therapeutic radiographer-led oncology podcast. So this is number 42. My name's Jo McNamara and I'm joined by fellow hosts Naeem and Jolka Anderson.
Hi everyone.
So a big thank you to our last guest, Professor Alan Pacey, who talked about fertility and cancer. So if you haven't had a chance yet, please do go and take a listen. So we're pleased to introduce our guest for this evening, Dr. Emma Hyde, who'll be discussing personalised cancer care within diagnostic radiography. So hello Emma, welcome, or should I say doctor now?
Hello Jo, hello Naeem, lovely to see you both.
No, it's great to finally have you on, and I know lots of the guests have been willing for a diagnostic radiographer to come on, so I'm sure the audience will be really pleased to see that you're on for today's podcast. So do you want to start by telling us a little bit about yourself and your career history, if that's okay?
Yes, of course, yeah. So I am a diagnostic radiographer, as you said, Jo. I actually trained at your very institution, Sheffield Hallam University, back in the 1990s. So I was one of the first degree students to come out of Sheffield Hallam. And then I spent 10 years working in the NHS in a variety of different diagnostic radiographer roles, specialising in CT and MRI particularly. So lots and lots of experience of working with oncology patients. Obviously CT and MRI makes up a huge proportion of the workload. So very, very used to that. I moved into education 16 years ago now, so at the University of Derby. So obviously started out as a lecturer first and then worked my way up to senior lecturer, then became the head of diagnostic imaging, and more recently I've now taken over management of the operating department practice and the osteopathy areas as well. So I've now got a really big discipline area with 4 different groups of allied health professions in. So I also recently got promoted to Associate Professor of Diagnostic Imaging, which I was hugely proud of because it's the first time at the University of Derby we've had an associate professor in diagnostic imaging. So that's a real landmark for us and shows how much the team has changed and research has changed at Derby over the last few years.
Amazing career. What made you decide to go into education?
It was quite a natural transition actually. So in my roles in clinical practice, I was always very interested in working with students. I enjoyed the buzz of teaching. As I was working in CT and MRI as a clinical specialist, I got very involved in teaching students who would come and spend a week or so with us. I used to love giving them little demonstrations of MRI safety. And as time went on, I just got more and more involved. So I started helping out with prospective student interviews. I started doing little bits of teaching here and there. And in my last clinical job, which was at the University Hospitals of Leicester, I was actually part of the teaching team in what they called the Imaging Academy back then, which was used to train their assistant practitioners. And so from that point, it was a really, really natural move because so much of my job at that point was to do with teaching or training anyway. So it was a very natural transition.
So in your current role, what does your normal day look like? You know, talk us through. Anyone who thinks, I really want to go into academia, what does it look like for you?
I would say that there's not a normal day. That's the first thing. It's very, very different every day. It really, really varies. Some days I'm in the classroom teaching students. Some days I'm in an online teaching session. Some days I'm writing learning materials, either for classroom or for online. Other days I'm busy with my leadership and management role in meetings. Other days I might be doing research. So it really is different every single day. And I think that's what keeps it interesting and keeps it stimulating, that there is so much difference. I guess it's the same with any job, isn't it? If you've got variety, it adds to the richness of it.
I suppose it's all the different kind of experiences as well that you bring into your teaching. So you have different backgrounds and kind of drawing it all together, which is quite nice. So I think you're looking into personalised care at the moment. What is personalised care for anyone listening, and how can it be achieved in radiography?
Yeah, so personalised care is a relatively new term. We've talked about patient-centred care and person-centred care for a long, long time, but personalised care as a concept here in the UK is relatively new. It's a phrase that's been coined by NHS EI to describe a certain type of approach to giving care to individuals. And it's about ensuring that that care is tailored to the individual's needs. So it's about not making assumptions about what people will want, what's important to them, what their values may be. It's about including them in discussions about their care, how they would like it delivered, and what the options are. So not assuming that everybody's going to want the same thing. And I think it's really like thinking about inclusivity, which is obviously a very important issue that's been in the media a lot recently. And it's the same sort of principle. It's about not assuming that everybody is starting from the same point. It's about actually to be giving the same standard of care to everybody. We might need to start from different points. So actually, it's better to think from an equity point of view rather than equality. And I think that just rings very true in terms of personalised care as well, especially when you think about the very different levels of health literacy and health awareness that there are within different groups of the individuals that we care for. It becomes really, really important when you start to think of it in that context.
Emma, could you give us any examples? I'm just thinking for maybe some students who are listening, who are thinking, okay, I kind of understand theoretically what you're describing, but some examples might help.
Absolutely. So personalised care in its truest sense, in the universal model of personalised care, talks around personalised care and support planning and shared decision making. So usually that's around, for example, treatment options, and obviously radiotherapy is a classic example of that. So an individual may have a choice of radiotherapy only, a combination of radiotherapy and chemotherapy, a combination of radiotherapy and surgery, etc. And in the true sense of the term shared decision making, it's about having that informed conversation with the individual and their family or carers, and helping that person to think through what is the best option for them without putting our own values and beliefs onto that conversation, letting them really explore what's important to them. And I know that you will both be aware of that from your own interactions with individuals, and you know it's quite a fine line, isn't it, to balance that. But I think obviously that's not within everybody's usual day-to-day role as a radiographer, and it can come down to really simple things like talking to individuals that we're caring for about what might seem quite small things, but things that can have a really big impact on their experiences with us as radiographers. So it might be about adjusting the lighting in the room to a level that is more comfortable for them. It might be about playing a particular type of music, putting a certain radio channel on, offering an extra blanket or pillow. All these things could actually come under the umbrella, and should, of personalised care, because we're tailoring our care to the individual and not making an assumption about what they may or may not want.
I suppose we'd all agree that despite time pressures, we'd want to deliver personalised or person-centred care. Do you think some people, it might not actually be on their priority list? If you think, I know Joe hates the term fluffy, but I'm going to use it again. As therapeutic radiographers, we always say we have the interpersonal skill side, but also the technical knowledge. Do you think that maybe if someone is a bit more technically advanced and that's the area that they prefer, how would they draw in that person-centred care?
I think, if I'm honest, from the research that I've done and the conversations that I've had with so many people over the last few years around this concept, it's something that we can all do, no matter whether we see ourselves as a softer, fluffier person or whether we see ourselves as very technically based. We can all do really, really simple things in every single interaction. For example, starting that interaction with "Hello, my name is," and explaining who we are and what our role is to gain trust and rapport straight away. That it can be an open gesture, a friendly smile, and a use of appropriate touch, a reassuring hand on the shoulder, a conversation about the weather or what was on the TV last night, although that's more difficult, of course, with streaming services. But just trying to engage with people on a really human level. And those things take no time at all. It's really easy for us to include in every single interaction that we have. They don't make the examination take any longer. They just take a little bit of thought to actually include within that examination.
I think people forget that, despite them maybe not thinking they're the most, open and honest with the patient. But even if you have a patient whose name you can't pronounce, I've seen people who would say they're not very fluffy or have great interpersonal skills, but they'll make sure that they're being sensitive and pronouncing it properly, or saying, "I'm really sorry, have I said it correctly?" But as you said, it's just finding that tiny little bit. That's more than enough for some people. They'll feel valued and listened to.
Exactly, yes. Yeah. I mean, an example that really sticks with me from my days as a very junior, newly qualified radiographer was assuming that that colloquialisms would make individuals I was caring for feel reassured and that I was there to look after them. And I remember calling a gentleman once, "Chick, would you like to come in, Chick?" Because where I worked at the time in Nottingham, Chick was a really common phrase. And this gentleman just looked at me and said, "Do not call me that." And I realised then that was my wake-up call, that you must never make assumptions. You always need to check what somebody would like to be referred to as during, what's their preferred name? How would they like to be referred to during your interaction with them?
Yeah, and there was some research we were involved in recently, which I was lucky enough to be part of the focus groups. This was one of the themes that came up, and it was really nice to see. I know some of the feedback, again, within the focus groups you got was there isn't enough time to do this. Obviously, I'm on the side of there is always time to do this, but do you want to just talk us a bit about the focus groups that you held?
Yeah, so thank you so much again for taking part in those. Your contribution was just fantastic. It was really great to have you there, being the voice of therapeutic radiography, so thank you. So the focus groups that you took part in, they were to actually validate some audit tools, weren't they? So what had actually happened at that point, the research that I'd been doing into patient-centred care in diagnostic radiography with my collaborator, Professor Marianne Hyde from the University of Bradford, had recently been published, and with that some audit tools had been offered as a way to potentially try and baseline measure levels of person or patient-centred approaches within imaging and radiotherapy departments. And the focus group that you took part in was to actually validate those audit tools, and they've now been finalised and are available free of charge for anybody to use, whether that's a student wanting to reflect on their own practice and how they are doing, or whether that's a departmental manager wanting to measure levels of patient or person-centredness within their department. So they're there free of charge for anybody to access.
And yeah, it was really, really interesting. So I've talked about this in a lecture before, but it's slightly similar. There's a book called Compassionomics, which has a similar kind of ethos where trying to measure compassion, which again is quite difficult to do because you can't watch everyone and everyone has a different level of it. But this is a similar concept where actually in healthcare, there's so many points where we don't realise we are being compassionate or empathetic. Yeah. And as you said, it's about measuring it. And I really enjoyed the focus groups. It's very interesting. I know I had to look this up because I didn't actually know about this, but there's an international community of practice for person-centred research. Just for anyone listening, it might be, if there's an area that they actually are interested in. Do you want to just talk a bit more about that so people could look it up?
Yeah, of course. So I joined this international community of practice about 6 months ago now. It's a group of active researchers who are interested in person-centred approaches in health and social care. So there's a whole range of different people in it. Some of them are in education, some of them are in clinical practice, and they're from all over Europe and different parts of the world. So we've got Australian and Canadian colleagues in there, people from all over Europe. There's nurses, there's occupational therapists, physiotherapists. I'm the first diagnostic radiographer in that group, and Gareth Hill, who you may know, is the first therapeutic radiographer in that group. So we're putting the flags out there for the radiography community. So to become a member of the group, you have to have evidence of your research into person-centred practice, and obviously Gareth and I have both done doctoral work linked to that, so hence why we're members. But it's a very welcoming community, and I'm delighted to be part of it and be working with the group now. So it's just a fantastic experience to talk to other people about what person-centred care is like in different countries and how different healthcare systems impact on the care we can provide.
And is the main aim of that group to then go on to do further research?
Absolutely, yeah. So there's a number of projects active at the moment, and there's also an active postgraduate group which I've just joined as well. So that's for people who have done a PhD in something person-centred. So it's really, really interesting getting involved in that as a new doctor myself. So lots and lots of interesting discussions happening within that group. Trying to think of some of the things that we've been doing recently. We had some really interesting discussions a week or two ago about defining how we were going to work as a postgraduate community of person-centred researchers. We're thinking about how we can not only embed person-centred practice into clinical practice with our patients, but also thinking about how we can bring it into education as well, which is really exciting. So I'm really looking forward to the prospect of getting more involved in that in particular, because there's so many similarities, of course, between how you interact with a student and how you might interact with an individual in your care in clinical practice. So that's really exciting.
Oh, it sounds interesting and definitely one to watch, because I'm sure the outputs of that will be pretty special.
Definitely.
I can see Joe's face
Emma,
just going like, oh, another collaboration maybe. Maybe there's another role here for me.
I'm not saying yes to anything else. So, Emma, can I just ask, obviously when we talk about personalised care or person-centred care, quite often another phrase that gets bandied around a little bit is social prescribing. What is social prescribing, and where would maybe a diagnostic or therapeutic radiographer or any of the allied health professions engage in social prescribing?
Yeah, so social prescribing is a really interesting concept that's gathered a lot of momentum over the roughly about the last 5 years. I'd say it started to really become much more mainstream. So it's an alternative to the medical model of care, which sort of is predicated on somebody needing some kind of medical treatment or actual drug prescription to provide them with the care they need. It acknowledges that sometimes what people need is some social interaction, an opportunity to try a new activity or hobby, a way to do some exercise in a safe, supported environment, with the aim being to improve their overall health and well-being. So a lot of GP surgeries now are employing what they call a social prescribing link worker. So this is a new emerging role where that link worker is able to advise different members of the GP practice on what's available within the local community, and actually work with patients from the GP practice to link them up to different social groups, to help them join, say, a walking group, or to go and join a craft group, or to link them up with other people that may have a similar kind of health condition to them, for peer support, link family members up for peer support as well. So it's really, really wide ranging and really, really powerful. And I think it really appeals to me because it's showing the power of looking at people from a more holistic lens, and actually it's not just about the actual medical side of things. That other side of things is really, really important. So for radiographers, obviously it's something that we might not necessarily get involved in on a day-to-day aspect, depending on what our role is. But I think for people in advanced practice roles, whether they're diagnostic or therapeutic, there's certainly scope that maybe a social prescribing approach may be helpful. Particularly, I think I can see the application of that in therapeutic radiography, where you've got lots of different things happening to individual patients receiving therapy. But also I can see perhaps with sonography as well, where there's probably quite a lot of links there. So the role that sonographers have is often to provide further advice and guidance, and I can see perhaps there's some links there too as well. So it will be interesting to see how we can grow into that role as professions. Of course, our wider colleagues in the other allied health professions are a little... some of them are a little bit more naturally aligned with it. So if we think about physiotherapists, for example, and occupational therapists, you could see straight away that there's quite a clear fit for them. But I think there is a role for any allied health professional to get to understand more about social prescribing and think about how they can potentially impact on the individuals they care for.
How do people become a social prescriber? So I love talking about exercise to patients. I've got my 5k away top on. I can't say that I socially prescribe because I don't know if it's regulated, so I don't want to get in trouble now. But I do recommend patients go and join a group or a Nordic walking group or something in the local area.
Well, I think something like that we can all do unofficially anyway, and I don't think there's any downside to that. The social prescribing formal roles that you see advertised for GP surgery are a specific role, but at the moment there is an association of social prescribing link workers, but I don't believe there is a formal registration process like there would be for us as radiographers. I'm sure it will come in the fullness of time. I think it's such a new role, though, that no one's quite sort of grasped where it might fit. So I'm sure it will come with time, though.
I'm sure, Joe, with your prehabilitation hat on, you probably can see your mind thinking there a little bit about it.
Yeah, I think it's definitely something, even from undergraduate education, that we try and encourage people to engage with their patients and thinking about how you can offer public health messages. So if you're talking to someone about fatigue, we know that exercise can help with that, or activity, and increasing your activity. So, although it may not be more formalised, we know that that's going to have an impact. If you have a patient who presents with mental health issues, you know that potentially increasing the amount of activity they're doing. I know from my own personal mental health, if I'm starting to kind of trigger myself, I'm like, I'm going to go to Cornwall and I'm going to walk the coastal path. That for me is therapy. And absolutely, I can see why social prescribing works, even from a personal perspective. There's definitely something about getting out into nature. And I know some of the podcasts we've done previously with guests, I think actually all of our patients that we've had on so far have indicated something to do with exercise as to what was their kind of their reassurance in getting back to being themselves, or their new selves after they've actually been diagnosed with cancer. So I can definitely see how maybe those roles will develop and evolve, but I also think it is really important that we do take responsibility for maybe not necessarily always classing it as social prescribing, but engaging in those conversations around personalised care. And I think sometimes, Emma, do you find that it's almost like where there's an expectation that as therapeutic radiographers or allied health professionals that you go out and look into your local communities around what is available? Because I often find that actually from an NHS perspective, there's less and less because of funding, whereas there are more charitable organisations now that maybe take over some of those roles.
Absolutely, yeah. I mean, we refer to it as the third sector quite often, those charitable organisations, don't we? And there's no doubt that is growing as a result of lack of NHS funding to pick up some of those things. So, yeah, I think becoming aware of what is out there in your local community is really key, and I would encourage everybody to take note of that and just to have that sort of ticking away in the back of your mind when you're talking to individuals and their families, and feel that you can offer that knowledge if you think that would be helpful to them. I think a lot of times it's confidence about, well, should I say this? Can I say this? Is it appropriate? And I think, if we can get the message out there and empower people and say, yeah, it's okay. That's fine. You can do that. It's absolutely okay. Please do that, actually, because the people that you're talking to about those potential activities or sports groups or whatever it may be, well, perhaps just don't know about them and would find that really, really helpful.
Do you think there's a bit of a difference here between kind of our diagnostic colleagues, diagnostic radiographers and therapeutic radiographers, where I suppose we as therapeutic radiographers see patients for weeks, so we have more opportunity within waiting room times or reviews or one-to-one in a maze going into the linear accelerator bunker, where we can have this opportunity to talk about exercise, nutrition. But for a diagnostic radiographer who might see a patient for a chest x-ray very briefly, do you think there's ample time for them to be able to do it?
I think you're right that it perhaps is a little bit more of a usual thing for a therapeutic radiographer to do, if you like, because you do have those repeated interactions with the people that you're caring for, don't you? You might see the same person for a number of weeks while they're having treatment. For diagnostic radiographers, I guess it's less common, but there are definitely still opportunities. I remember in my own clinical practice days, particularly working in CT and MRI, where you would have commonly oncology patients coming back for surveillance scans every 6 weeks to monitor how well they're responding to treatment. So there definitely are, and I definitely built relationships with quite a few of the people that I used to see. And I have a story that I tell the students about a particular patient that I formed quite a bond with, who did unfortunately then pass away. But that was very upsetting for me, because that wasn't something I had previously been used to until I worked in CT and MRI and started to have those repeated relationships. So I think there definitely are opportunities out there. It's about grasping them and seizing them, isn't it? And thinking what you can do.
Yeah, making every conversation count.
Making every contact count.
Every contact count. Sorry.
Yeah, that's that. Sorry, yeah, that's no. It's a really it's one of the sort of buzz phrases to do with personalised care. Making every contact count.
I'll make sure I never get it wrong now. Sorry, Dr.
Yeah, sorry.
So Emma, you were awarded a National Teaching Fellowship, as you mentioned, by Advanced HE. Can you tell us a bit more about it?
Yeah, absolutely. I was absolutely delighted to get that. Obviously, in the educational world, a National Teacher Fellowship is a very prestigious award that recognises that you're achieving national impact with the things that you're doing. So I was really, really delighted when I was sort of given the nudge to say, you really ought to do this. That was nice enough in the first place, but then to actually finally get, go through the process and be awarded was fantastic. So it was quite a bit of work to put together the claim, they call it, for the National Teaching Fellowship. And I wrote it around my own research, obviously, looking at patient-centred approaches. I also talked about how I've worked really hard to create a research active team culture within my team at the university. And I also talked about my leadership and management of embedding simulation as a cornerstone of our teaching practice at the University of Derby, something that we've got a really strong reputation for. So those three things together formed the basis of my claim. Obviously the research was underpinning teaching, my team being more research active was underpinning teaching, and simulation being the cornerstone of our teaching approach was again informing and informing our teaching practice. So it was all about improving teaching for the benefits of our students and ultimately, of course, the end users, the people that we care for in clinical practice.
As someone as who keeps getting the nudge to go and do things like this, I keep reading about how much work it takes. So it's amazing that you got it, Emma. Absolutely amazing, and it's great for radiography as a whole to kind of have role models, real life role models, as Janice would call them, to kind of motivate everyone to think about going for opportunities like that. Emma, you commented a little bit about kind of creating a culture, and I know sometimes that's something that we say a lot of in academia. How would you go about maybe creating more of a research culture within clinical? Because I know it's something that we can kind of get our heads around in academia, and you're actively encouraged to obviously pursue research, but what do you think we need to do to be able to generate more of that culture within the clinical setting?
I think it's about support for peers, because I think when you're a new researcher, when you've not got much experience, when you haven't published before or taken things to conference, it's a really, really daunting prospect. I remember my first publications and conference presentations, my knees were knocking, I was shaking, I was in a terrible state. It was really, really daunting. But as you do these things more and more, they get easier and easier. But one of the key things I think is collaboration, about not trying to go it alone. And I think sometimes people think they have to do it all themselves. It's got to be all their own work. Actually, collaboration is the best way forward. You get so much out of it. And I've now collaborated with lots of people within the radiography community here in the UK. I've also now got international collaborators as well, looking at international perspectives of person-centred care, which is fantastic. And that's what I've tried to embed within my own team, around peer support, buddying people up, helping people who are less experienced, supporting them to put together an ethics application, and then helping them collect data and write that up. That's been the way that I've done it. And I would encourage the people that in clinical departments have got that experience already to really think about, well, who's the young talent in their clinical department that they could support and work with and nurture. I was really proud last week that a colleague that I've been working with that is based at University Hospitals of Derby and Burton published in Insight about the experience he's had setting up a journal club within the trust. And I had helped him. I didn't expect him to name me on the publication, but he did, and it brought a little tear to my eye. And I was so proud of him for what he's done. It's absolutely fantastic what he's managed to achieve. So I think if we can try and encourage people to offer that support to our new young bright things, that's what we need to do, and grow our talent, don't we?
Definitely. And yeah, I did read the Journal Club one. It was very nice to see.
It was, wasn't it?
Yeah. You talked about the international collaborations, Emma. Just wondering if you found from different communities is there a big difference between person-centred care due to cultural backgrounds or religion?
So we don't actually know yet. We're just starting to collect the data. So the other universities that I'm working with have only just finished going through the ethical approval process. So we haven't got any large amounts of data yet to start making any conclusions, drawing any conclusions from. But we do expect to see that different healthcare models are going to impact on it. We think without a doubt that they probably will. And we do expect to see countries with very rural communities that has an impact as well. What that impact is, we'll obviously need to wait and see, but that is what we're anticipating. But interestingly, I am working with a PhD student in Ghana at the moment who's also researching person-centred care approaches, and it's really quite striking already working with her, the differences that what she perceives from feedback that she's had as person-centred approaches is quite different to what I would see. So we've had some really interesting dialogues about that, and that's all down again to the funding of the healthcare systems and expectations of health within the Ghanaian system. So really, really interesting, and I'm looking forward to seeing what comes out of that.
Do you mind me asking what sort of differences?
So hopefully I'm not breaking any confidences here, but one of the key things she's identified straight away is around waiting times, because in their healthcare system in Ghana, that there is no such thing as an appointment time. You go and wait. You go to the hospital and you wait for your appointment. Well, it isn't an appointment. It's you wait to be seen. So the thing that's coming through for her at the moment is around how do they reduce waiting times so that they can give better care. And that to me I was like, gosh, okay, so in the research that I carried out, waiting times came through as important, but they came through as important in terms of knowing how long you needed a parking ticket on your car, or what how would that affect which bus that the person was going to catch home, and things like that, or were they going to be able to go back to work after the interaction. So completely different mindset, and really eye-opening for me. And I felt a bit silly, really, not realising it. If I'm honest, I felt a bit like, of course, I should have realised that. But it's so different, and I think we're used to what we're used to, aren't we? We are acclimatised to whatever country we're living in and the systems and how they work there. And I think that's where international collaboration is really, really rich, helping us to think about those differences and what we can learn from each other.
Yeah, we're very lucky to have the NHS, and I think there are countries, we've talked about this on the podcast before, Joe and I, that there are countries that have one linear accelerator for the whole country, one clinical and maybe one medical oncologist, and that's just normal. They never have a day off, basically. But do you think, you might not have come across this yet with your research as well, but do you think personalised care is different between public sector and private healthcare? Or the priorities might be different? I
think that there probably is something in that. Unfortunately, we didn't get enough private providers, or independent providers, as I think they prefer to be called, taking part in the original research. But that it could be a really interesting follow-up piece of work, because I think from the private or independent providers that we did have involved, you could see differences without a doubt. And I think just the fact that often workload is more planned in those private and independent settings, because they're not at the behest of emergency departments, for example, which can, in diagnostic radiography, can really disrupt things. So the fact that it's more planned episodes of patient care, I think, does make a difference, and it would be interesting to explore that further, definitely.
You could also imagine that they have more workforce available, don't they, to be able to kind of refer to. So if someone did have a condition that required physiotherapy, they could have that at the same time as then obviously attending for a CT or an MRI, rather than maybe having to wait
absolutely
6 months. Maybe being optimistic.
Yeah.
So Emma, we're moving on. We're getting to the end. You've actually given us loads to think about, and I'm sure people listening will already be taking lots away with them. But have you got any hints and tips for, any patients out there who maybe are considering, well, how can I engage more with my healthcare practitioner around person-centred care, or any students who might maybe lack the confidence to start having those conversations, and also thinking about healthcare professionals listening, what is it that you would maybe advise them to start doing to make these changes in practice?
Well, let's start with the patients. I think, first of all, my expectation that every healthcare professional should start an interaction by introducing themselves and using the "hello, my name is" phrase. In my opinion, there's absolutely no excuse for anybody not using it ever, because it takes no time at all. So I think you should know who's caring for you, and if you don't, I think it's absolutely fine to say, would you just mind telling me what your role is? And trying to engage the person in that dialogue, because at the end of the day, we are all human and we don't know what's going on for other people. And the pandemic really highlighted that, didn't it? That we don't know what else people are dealing with. And it could just be a genuine oversight. So I think if patients can, try and encourage that conversation, show radiographers that they want, or any healthcare professional, that they want to have that kind of dialogue, I think that's really great. I'd also encourage patients to vocalise what they want as well. I know a lot of patients in the NHS particularly of a certain older age group, are just so grateful sometimes for you doing their x-ray or providing their radiotherapy treatment, that they almost are grateful for anything they get. And that's not to disparage what they're getting, but it's a certain mentality, isn't it, of anything they get is brilliant, and they would never complain because they're so grateful for what they've got. And often that's to do with, particularly with older patients, to do with the fact they can remember the days when there wasn't an NHS. So I think just making sure that patients know they can ask for things. If they're cold, they can ask for another blanket. If they need a pillow under their knees, they can ask for that. They can ask for the lights to be turned down. They can ask for the music to be changed. Whatever it is, it's okay. It's absolutely okay to do that. And, if it's a parent with a young child who needs a quiet area, or if it's a carer with a person with dementia, that needs a quiet area, all these things are fine. And it's okay to ask for those things. It's absolutely fine. And I think often people don't, because they don't want to be trouble. They don't want to put the healthcare professionals out. And I think I would encourage patients to vocalise those things. With students, I think it's about remembering that the small things can make all the difference. So actually, it's amazing the impact of a smile on somebody, So just smiling at somebody, being friendly, as I mentioned earlier, appropriate touch, open body language, friendly, welcoming. How can you make them more comfortable? How can you help them maintain the position that they need for the imaging examination or the therapy treatment? What can we do to make them feel more comfortable, less vulnerable and less afraid? Because hospitals are daunting situations, especially in the areas we work in, where we've got big pieces of kit. It's often quite cold. The air conditioning is often a bit fierce because it has to be because of the kit. So how can we make them feel more comfortable and less vulnerable? And then for healthcare professionals, I'd say please do look at the Personalised Care Institute website. It's excellent, free CPD. There's a range of short courses, webinars and podcasts on there that you can go on to and access, that give you a nice certificate to say that you've done some CPD, that you can then use for your HCPC or NMC audit, and you'll learn something about personalised care and about how you can integrate that into your practice. And they're suitable for anybody, absolutely anybody. So please take a look at that. It's really easy to find it. You just type in Personalised Care Institute .org.uk, but Google should find it before you've even got that far anyway. So it's all in, it's provided by the NHS. It's all endorsed, and it's a really, really good source of information.
Oh, thank you, Emma. We'll definitely link it as well with the podcast. So if for
you.
any reason people don't want to even Google it, they can just link directly from the podcast. So that's fine.
Fantastic.
I really like the points you made about being a patient, actually, because I've had it, and I'm sure you would have both experienced it. You know, where a patient does ask, never have I gone, oh, God, I can't believe that patient's asking for that. I always go, oh yeah, of course, absolutely.
Yeah.
Or if they're like, actually, I really don't like this song, please can we turn it off, or can I have it in silent? It's one of those, isn't it? I think being a patient, and on the other side, I can also see why I'm sitting there going, oh my gosh, that's really painful. And they've asked me, does that hurt? And I'm like, no, it's fine, it's fine.
Exactly.
Keep going. And inside I'm like, I'm going to pass out.
Exactly. We all do it, don't we? We don't want to be a bother. It's a really British thing, and we need to be more honest about how we're actually feeling.
Yeah, absolutely. So any patients listening, know that you can ask your healthcare professional for anything. If they can't for whatever reason, then it should be explained, shouldn't it?
Yeah.
And we should be able to kind of have that two-way conversation about why maybe something can't be undertaken, or organising it for next time.
Yeah,
I think it's so important. Yeah. So thank you so much again for listening to Rad Chat. Your hosts today have been myself, Jo McNamara, and Naaman Jolka Anderson. A huge thank you again to our guest, Dr. Emma Hyde. So head over to the YouTube page to see a live recording of this podcast. And if you're utilising the podcast for CPD purposes, consider the reflective questions posted along with the links to resources and literature we've discussed. To receive your accredited CPD certificate, please complete the Google form linked with the podcast. So our next guests to feature will be Catherine Holborn and Emma Hallam, and they'll be discussing survivorship after radiotherapy. So thank you for listening and take care.